So continuing with question number 33 of previous NEET question. 50 years male with known history of refractory hypertension on multiple drugs comes to the clinic for routine follow-up. His ECGs are shown below. So it's a straightforward one-liner of ECG. So what can you make out from the ECG? Okay, we are asked to find out a drug reaction or a drug adverse reaction which is manifesting in ECG. So I think one thing can be made out. Patient is having tall T waves, right? So when do you say T wave is tall? Normally T wave height is only 20 to 40% of the QRS complex. The T wave should be smaller than the total height of the QRS complex. But see this case. The T wave is nearly equal to that of the QRS complex. So that is called as tall T wave. So tall T wave occurs only in two conditions. One, it is hyperacute MI. That is, even before acute MI, the ST elevation phase occurs, tall T waves can occur. The second thing is hyperkalemia. These are the two conditions where tall T waves occur. Okay. So this is a tall T wave. We have to find out a drug which causes tall T wave. Prazosin, the side effect is it's a very potent vasodilator, so it causes only hypotension. It's not known to cause any significant ECG changes. Metoprolol, it is a beta blocker, so it causes bradycardia. So if you calculate the heart rate here, we know the formula very well. Heart rate is 300 divided by number of big squares between two R waves. So here it will be around 4. So the heart rate is around 75. There's no bradycardia. Okay, so metoprolol cannot be the answer. Hydrochlorothiazide, remember in one of our previous discussion, we discussed that thiazide diuretics and Gentleman syndrome are together. So many electrolyte imbalances occur like hyponatremia, hypokalemia, hypomagnesemia. But what does not occur? Hypocalcemia does not occur. That occurs with thiazide diuretic. So hypokalemia, the ECG changes flat T wave. Actually, many changes occur based on the level of hypokalemia. There can be flat T waves, there can be U wave formation, okay, there can be sinusoidal wave or flat waves, but none of which is given here. Here T waves are very distinctly tall, okay, so this cannot be the answer. What does hypomagnesemia manifest with? Manifest as QTC prolongation. Again, in one video we were discussing the causes of QT prolongation. Okay, first, how will you say QT is prolonged? So there are many formulae to calculate QT. Like one formula is called Besset's formula. You can read it up. But by seeing the ECG, especially in the last minute NEET stress, if you have to diagnose something, try to mark two levels. That is, mark the RR interval first. See, this is the R wave peak. This is another R wave peak. So this is your RR interval. Next measure QT interval. So again Q begins here, right? So Q begins here and T wave ends here. So this is your QT. So when do you say QT is prolonged is QT is said to be prolonged when the QT C interval or QT interval is more than 50% of RR interval. So this is a simple visual clue to diagnose QT. So maybe in another place we can see. See, roughly this is the RR interval and this is roughly the QT interval. You can see it is around 50%. It's not exceeding the 50% here. So if the QT interval is more than 50% of RR interval, then QT is said to be prolonged. So there are many reasons. There are many drugs which cause QT prolongation, like fluoroquinolones, antimalarials, many antipsychotics can cause. Then there are many electrolyte abnormalities. Hypokalemia can cause QT prolongation. Hypomagnesemia, hypocalcemia, all these cause QT prolongation. Then we know very well the long QT syndrome, congenital long QT syndrome. So these are some causes of QT prolongation. So here QT prolongation is not that much marked by the visual assessment. So what is very clear is there is a tall T wave. So spironolactone, one of the side effect is hyperkalemia. If you remember another side effect, it is one drug which causes gynecomastia. Okay. So suppose if you are very confused with the ECG initially, just read the question and try to fit whether the ECG comes. Iprazosin will cause only hypotension. It cannot be picked up in ECG. Metoprolol causes sinus bradycardia. Then try to calculate the heart rate. Here it is normal. So B cannot be the answer. Hydrochlorothiazide will cause hypokalemia, hypomagnesemia. So it has to cause flat T wave, but T wave is very prominent. Spironolactone has to cause hyperkalemia, which causes tall T wave. Here there are tall T waves. So like that you can match and try to answer even if you don't know the ECG or if you get tensed with the ECG. So I told you hypomagnesemia causes long QT, hypocalcemia causes long QT. So what does hypercalcemia cause? It causes shortening of QT interval, short QT interval. So once again revising, hyperkalemia, the classical hallmark is tall T wave. Of course, many other changes occur. Like we can get a sinusoidal, we can get a cardiac arrest. Then what about in hypokalemia? Initial one is a flattening of T wave. Then there can be U wave formation. U wave is a positive wave after T wave. And what happens in hypocalcemia or hypomagnesemia? QT prolongation. And what happens in hypercalcemia? QT shortening. And try to correlate it with the drugs. Then digoxin is also a very important MCQ. We get this typical hockey stick appearance in ECG. And we may get atrial premature complexes. They are specifically atrial bigeminy. So you can read the ECGs. You can see the ECGs and get oriented. Coming to question 34 of NEET PG. So a patient with previous history of myocardial infarction and ventricular arrhythmia is on treatment for a few months. He developed fatigue, dyspnea and weight gain. He also has pulmonary fibrosis. Which of the following drugs causes it? So again it is a pharmacology plus medicine integrated question. It's pretty straightforward question, but the question may look a bit vague because patient has been given adverse effects of fatigue, dyspnea and weight gain. Like many drugs can cause all these effects, but one clinching word here is the word pulmonary fibrosis. There are only few drugs which cause pulmonary fibrosis, like methotrexate, the chemotherapy drug busulfan, amiodarone, etc. So from this thing, amiodarone is the answer. So it's a straightforward question. We know metoprolol is a beta blocker. It causes sinus bradycardia. Aspirin is a it's an NSAID, non-specific, non-steroidal anti-inflammatory drug. So its main side effects are GI bleeding and gastric ulceration. Spironolactone in the last question we discussed. It causes hyperkalemia because of its aldosterone antagonist effect. So amiodarone is specific, causing pulmonary fibrosis. Amiodarone also can cause hepatitis, and one important side effect is thyroiditis. Remember, amiodarone is one of the drugs which is used for rhythm control in atrial fibrillation. But in atrial fibrillation due to thyroiditis, amiodarone may not be preferred because amiodarone itself causes thyroiditis. There are two types of amiodarone-induced thyroiditis, type 1 and type 2. Try to read them if you can, but otherwise, to be simply frank or with the simplest context, amiodarone causes thyroiditis. Okay? So case scenarios may be given, and amiodarone, one of the specific side effect is pulmonary fibrosis. It also causes few corneal opacities. It can cause skin discoloration. So these are very favorite one-liners.